Good afternoon or good morning, everyone. Thank you for joining us today to discuss a topic that is of grave importance, but one we have shied away from for decades: mental health, and in this case, mental health and insurance. If there is at least one silver lining we can find in the COVID-19 crisis, it is this one. We are finally talking about it. I am Adrita Bhattacharya-Craven. I lead the Health and Aging Research at the Geneva Association, and I'll be speaking and moderating the webinar today. Today's webinar is divided into three parts. We will start with me sharing with you the key messages from our recently published report. Following this, we will be bringing you insights from our panelists who represent three different worlds: the insurance industry, the policy world, and the clinical world, to paint a very holistic picture of mental health. And finally, we will aim to dedicate about 20 minutes to then hear your views and take questions, and I really look forward to your participation. Now for some housekeeping. During the Q&A session, you will participate in two ways. You can use the raise hand function to ask a live question and we will unmute you, or you can use the Q&A function to submit a written question, which can be done at any point during the event. Also, towards the end of the webinar, you will be presented with a short survey, and I really hope you can help us improve these events by filling it out. So with that, let's begin by introducing you to my speakers today. I am joined by one of my co-authors, Dr. Sam McHale. Sam is the Director of Mental Health Solutions at Sun Life, where he drives thought leadership in the prevention, management, and treatment of disability claims related to mental disorders, and contributes to the development of strategic initiatives focused on mental health. He is also a registered psychologist in the province of Ontario and is a board certified in clinical psychology with the American Board of Professional Psychology, and has remained an active clinician, researcher, consultant, and an educator. We also have with us Gordon Watson. Gordon is the Chief Executive Officer of AXA Asia and Africa, responsible for the operations in 18 markets in these regions, including some in the Middle East. He also leads AXA Emerging Customers, which is a unit focusing on addressing the insurance needs of low-income population segments. He is also a member of the group's management committee, and as some of us already know, he has been an untiring advocate of mental well-being. And last but not the least, we have Christopher Prince. Christopher is a senior economist in the OECD's Directorate for Employment, Labor, and Social Affairs. He joined the OECD over 20 years ago and has ever since been responsible for the work of the organization on the links between mental health, disability, and the labor market. Christopher has written numerous OECD reports, including some on integrated mental health skills and work policy that's been endorsed by employment and health ministers of all OECD countries in 2016. A very warm welcome to you all, and it's great to have you here. Just as a warm-up exercise, I wanted to gauge the temperature in our virtual room today, and I'd like to invite my audience to answer two questions before we delve deeper into today's presentation and discussion. Can you please open the first question, please? The first question is really gauging your description. Which statement best describes your interest in mental health issues? I'll just give it a few seconds for people to answer this question. Thank you. We have another question we would like to ask our audience today. So can we please open the second question? So the question is, in your view, mental health is an issue to be addressed by, complete the sentence as you see fit. Great. Well, thank you very much. Now, before we discuss these questions, they will come up during the course of our presentation today, but hold on to those thoughts and let's go into our presentation. So the next slide, please. So what led us to work on this? On the left-hand side, you really see some headline messages. 1 in 8 people live with a mental health problem. That makes 1 billion of us. In this room, if we take the number of registrants, we had close to 500, about 480 registrants. So we are talking about at least 60 people having some kind of a mental health problem. That is significant. During the pandemic, we have seen a significant increase in the cases of anxiety and depression, and there is a good chance that the real numbers are much higher. Yet, until very recently, we haven't really spoken much about mental health, particularly in the context of insurance. And yet insurers are at the forefront of absorbing the shocks, which we will explore in a bit, in quite some detail. On the right-hand side, you can see what we had set out to do. We wanted to define the scale of the burden. We wanted to examine the current role that insurers play in mental health. And finally, we recommend steps to further boost its contribution towards mental health. The next slide, please. So, thank you. So we refer back to our first polling question. We asked what drove you to come to this webinar today, and 36% of you said you came here because you think mental health is a very growing risk. Well, you're very right. In this diagram that shows the ranking of the global burden of disease by health condition, you can see in 1990, mental health problems ranked 13. Now it ranks 17. What more, if we look at a more disaggregated level, for women, it used to be 12. Now it's the 6th biggest reason for ill health. For young people aged 15 and 14, between 5 and 14 years, it has moved from being the 8th biggest cause of ill health to being the 2nd biggest cause of ill health. And for people between 15 and 49 years of age, i.e. teenagers, young adults, working age, it is the #1 reason for ill health. So when it comes to the scale of crisis, it's the women, it's the young, and it is the working age that we need to be most concerned about. And those new cases of depression and anxiety we showed at the very first slide, 2/3 of them have actually affected women. So indeed, you're very right, the burden of mental health has increased dramatically in the last 30 years. But the burden has also fallen unequally on different segments of the population. The next slide, please. Then we refer back to our second polling question. We asked, in your view, who should address the issue of mental health? And I think, as expected, 68% of you said the broader industry should. Actually, you are right. The answer is, in fact, everyone. On the left-hand side, if you look at the risk factors of mental health, the biological and the behavioral factors, which have strong crossovers with medicine, are very important. But they're just the two. The vast majority of everyday emotional well-being is being dented by socioeconomic reasons and our living arrangements, our circumstances, making this a much more complex issue. Its monetary and non-monetary toll is also complex. You can read this list that you have on the right in your own time, but a few are worth mentioning here. In the EU, the indirect costs of mental health were 25% higher than direct cost to health systems in 2018. Insurers pay about $15 billion in claims from income protection or disability insurance claims related to mental health, not health insurance. And health insurers, irrespective of them covering mental health or not, are picking up some of the costs in some other way. And you can see how poor mental health is associated with 29% higher risk of heart disease, 32% higher risks of stroke. So there is very little on this slide that tells us mental health can be solved by health systems alone or through clinical interventions alone. It goes beyond the health sector or a mental health institutional care setting. It needs a multifaceted response to tackle the source of the problem, but also to manage the problem when they occur. The next slide, please. So how does the different lines of insurance interact with mental health? There are 4 different lines. So life insurance, health insurance, general insurance, and liability insurance. Our report specifically focuses on life and health, where most of the cost is incurred and where there is a real potential to do something about it. But few factors get in the way when it comes to the insurability of mental health. Firstly, there are exogenous factors, stigma. A report by Human Rights Watch showed that the practice of shackling the mentally ill is prevalent in still 60 countries across Asia, Africa, Europe, the Middle East, and the Americas. In a study of Singaporean young adults, over a fifth have difficulty admitting they have mental health problem because it could be seen as a weakness. In countries like the UK, just 54% feel comfortable talking openly about mental health at their workplace, despite the fact that workplace burnout, financial stress are among the leading factors for poor mental health. This poses a barrier to disclosure. That's where the stigma really comes in. Then it comes to resources. The median number of mental health workers per 100,000 people in 2020 was just 13, with stark inequity in their distribution. The median number of mental health nurses per 100,000 people in Europe is around 25. It is just 0.9 in Africa and Southeast Asia, some of the most populous parts of the world, and the norm really varies. Then there are endogenous factors, insurance-specific factors. It is difficult to have market intelligence about what people find acceptable or not, what people would use or not, with so much stigma attached to mental health. So it's a problem with consumer engagement and awareness, but it's also a problem with designing a product. Also, traditional underwriting techniques that apply to health somewhat unravels when it comes to mental health. Have you a broken leg or not? Have you had an operation or not? Those are straightforward questions with straightforward answers. In mental health, that doesn't really work, as mental health is indeed on a spectrum, which I hope we'll come to in our conversation a little bit later. And similarly, people may not know they have a mental health problem. Diagnosis may vary and it may be subjective. Severity may be understated or overstated, all of which make risk assessment really difficult. And as a result, claims validation processes also end up being quite cumbersome in the context where clinical pathways may be missing. What is legitimate? Was the inpatient episode really necessary? So it requires going through clinical records, employment records, and it is possible that while all of this is being considered, a user's mental health might be getting worse. The next slide, please. But good work is underway. The report highlights a number of examples of where innovations are taking place. But if we were to pick on some major themes, we would say service innovation is happening in prevention and creating an ecosystem of support. So not just an app, but actually having a whole range of services around it to take a user through a journey. As you can see, we have customized group plans, we have technology for early diagnosis of stress, we have the Learn, Act, Chat framework. Similarly, there are operational innovations also happening, particularly in underwriting. Some insurers are slowly moving away from binary questions of assessing risks to multivariate ones. So not just have you suffered from depression, but also when was it? How do you feel now? Have you been treated? How many sick days have you had in the past 6 months? These are also then coupled with population level data when they're available. And it has improved insurability from 16% to 56% in some cases for life insurance products. The challenge for the industry is now to achieve scale for these innovations. So what more can insurers do? The next slide, please. So we have made 3 suggestions. Right now, most of the products focus on very complex mental health problems, inpatient treatments, visit to the psychiatrist, etc. whereas the bulk of the burden is coming from anxiety, depression that could be workplace related or something to do with financial well-being, etc. So we invite our insurer colleagues to look at the local and the global evidence against what you are doing now in mental health and decide, what do you really want to cover? How much of it do you want to cover, and who do you want to cover? So it's really understanding the scale, scope, and the depth of coverage based on existing evidence. Then it comes to engagement. We see the need to really engaging your customers in the product, be individuals or corporates. Just including mental health benefits in the package may not be enough if people are not really going to use it. And we saw what a widespread problem stigma is in this context. And finally, optimizing the insurance functions, moving away from binary to multivariate approaches to underwriting, and also using population level data to understand where those risks exist and putting the two and two together. Leveraging the data that you have from claims, understanding the triggers, the timings, when could you have intervened early to manage it? Are you overseeing something? It can bring intelligence. It can also help to reduce the size of the claims, but it may also mean then some products have to revisit the 3 to 6 to a year long 3 to 6 months or a year-long postponement clause that quite a number of products currently have in order to enable you to intervene early in a person's journey on mental health. Finally, using data and intelligence that you have amassed through underwriting and claims and creating a hub. This is particularly true in group plans. At present, imagine you have a large corporate client where you're providing income protection insurance, disability insurance, health insurance, occupational health, EAPs, and there's a real risk of overlap that you may be paying for something twice in a different way, or that you're ending up with a long claim when it can be shortened through another intervention. Is there room to create a hub and to triage and redirect a user to the right level of care? What could that be? That could be clinical care, social care, financial care, or even a combination of the three. So let me pause there and bring in my first speaker. Sam, this is a question for you. We have just reflected on some of the challenges of understanding mental health. You are probably the most clinically qualified person to talk about it here, I think. Can you please demystify for us what we really mean by mental health and what is so unique about it?
Certainly, Adrita. Thank you so much for inviting me, first of all. I'll ask for the slide to be put up as an aid for responding to this question. In its simplest terms, mental health is a state of a person's psychological, emotional, and social well-being, what we typically refer to as a biopsychosocial model of mental health. Mental health really is a core component of our overall health. It's shaped and it's defined by a number of dimensions of the person, including their biology, things like their genetic predisposition, the prenatal environment at the point of conception and during pregnancy, the individual's temperament, and so on, as well as formative relationships, particularly early life relationships, the quality and availability of social support throughout the course of life, and so on. And then aspects of a person's physical and social environment. I'll have the second slide, please. Now, to be more precise, the World Health Organization defined mental health as a state of well-being in which the individual realizes his or her own abilities. They can cope with normal life stresses, can work productively and fruitfully, and they're able to make a contribution to their community. So it's very all-encompassing. I'll have the next slide, please. One of the things that I do want to underscore, though, in trying to understand the nature of mental health is that although mental health and mental illness are related, they're very distinct but coexisting entities. In fact, a person can have a reasonable degree of mental health, or what we sometimes refer to as flourishing, while also experiencing a mental illness. A really good example of that is the Nobel Prize winning mathematician, John Nash, whose story was the subject of the movie A Beautiful Mind, if people had the opportunity to see that. Nash was a professor at MIT who was awarded numerous honorary doctorates by leading academic institutions the world over. But in 1959, he began to show signs of mental illness that included paranoid delusions and both auditory and visual hallucinations. He was eventually diagnosed with schizophrenia, and over the following decade, between 59 and 69, was had to undergo fairly extensive psychiatric treatment, including hospitalization. But despite that illness, Nash made considerable contributions to mathematics, to game theory, and to economics, and was awarded some of the most prestigious prizes in those fields, including the Nobel Prize for Economics in 1994. So here we see someone who lived with a mental illness that certainly impacted his life in very significant ways, yet managed to flourish intellectually and academically, and was able to make significant contributions to our world. In fact, many of Nash's economic theories are still very much at play today. But we also have numerous examples much closer to home. Certainly at Sun Life, we've had the benefit of hearing from a number of our leaders and employees who clearly excel at what they do and have made very significant contributions to the work at Sun Life. They've been very generous in sharing their own mental health challenges. And that kind of open conversation, I think, has been very, very important for us at Sun Life. Those individuals really serve as very accessible examples and reminders to everyone who works with us that mental health is certainly part of our everyday. Now, another important World Health Organization document on the issue of mental health versus mental illness comes out of the Ottawa Charter. It's a document that captured the proceedings and the recommendations of the World Health Organization's first international conference on health promotion. It was held in Ottawa in 1986. The Ottawa Charter stated that to be healthy, a person or a group must be able to identify and to realize aspirations, to satisfy needs, and to change or cope with their environment. It really underscored that health is not only a function of our physical and mental capacities, but it also hinges on social and personal resources. And that what's essential to a state of health then are conditions and resources like peace, shelter, education, food, income, a stable ecosystem, sustainable resources, social justice, and equity. So it really underscores, I think, what you said, Adrita, that this is something that goes far beyond just simply looking at things from a medical or simply a clinical perspective. Now, when we think about that list, if those are essential ingredients to health, then when we consider the impact of the pandemic, global geopolitical instability that we're experiencing today, and we have for some time, the effects of climate change and the erosion of the world economy that has really been going on the last number of years, the decline in global mental health that's documented in the GA report is certainly very understandable. I hope that that helps.
Indeed, it does, and it captures so many messages from the report itself, Sam. And I think, in a way, the biggest revelation for those of us who worked in health, but not necessarily so closely on mental health, one thing has become very apparent is how transient it is and how we think about it in a static way. You can have a mental health problem, but be completely functional. At the same time, you may have a transient issue that make your life very, very difficult for a very short period of time. So it's the ambiguity. So that brings me to the second question I'd like to ask you, Sam. The frameworks, this is a very nuanced framework, but how do you make this work in real life? How do you resolve these ambiguities, and how is Sun Life doing it? Can you give us some examples?
Certainly. If we could just advance the slide, I'll go through some things I think that we've done at Sun Life that have been really helpful. First of all, I want to just underscore again a point that you made, Adrita, that when it comes to mental health, one of the greatest challenges that we face in society is a very real and significant knowledge gap. We've made significant strides, I think, in disease prevention by educating people about the harmful effects of smoking and substance use, the importance of good nutrition and physical activity, and taking preventative measures like cancer screening or undergoing a regular physical exam. Unfortunately, that hasn't been true in the case of mental health. There, we've fallen far short of the mark. Many people pay little attention to their mental health, let alone consider going through a periodic mental health check with a qualified professional or completing a self-screening instrument. There are a number of factors that contribute to that gap. Again, as you mentioned, stigma, misinformation, limited access to services, the cost of mental health care, and simply not knowing where to begin and where to go. So in response to some of those barriers, Sun Life created Lumino Health, which is an all-in-one health hub that provides access to tools and resources to support Canadians, or anyone for that matter, in their health journey. It contains credible, curated health content that includes articles, guides, interviews. Some of our own staff interviews are on there, and a provider search tool that helps an individual locate a healthcare provider in their particular area. Those resources are free and available to anyone with an internet connection. I'll have the second slide, please. Now, as you know, Sun Life also provides extended healthcare and income replacement benefits through employee benefit plans. There, we've taken a number of steps aimed at enhancing the well-being and mental health of our clients. For example, we've encouraged employers to provide mental health coverage in their extended healthcare plan. That's in keeping with the recommendations of the Canadian Psychological Association. That was indicated on the last slide. So somewhere in the order of $3,500 to $4,000 Canadian annually. We've also encouraged employers to choose plans where there's no requirement that a person obtain a physician's referral in order to access psychological services. That not only supports easier access, it also contributes to reducing net costs incurred by our public health system, since a person doesn't have to see their physician. We've created a flexible suite of options that make it possible for an individual to select a level of service based on their particular needs and circumstances, be that self-guided online modules, virtual care, or in-office care. We've also created and offer anti-stigma campaigns to employers so that they can begin to address issues of stigma as a barrier in their employees. We provide support in assessing and enhancing psychological health and safety in the workplace through use of proprietary organizational assessment tools that looks at the culture within an organization. And finally, we provide manager mental health training that helps leaders recognize when an employee is struggling and may be in need of support, rather than automatically assuming that it's a performance issue. I'll have one more slide, please, and I'll just go through one other thing. Our most recent innovation is a resource called the Mental Health Coach. It's a service that takes a user through a mental health screening questionnaire. Typically, this is emailed out to employees through their employer platform, and it provides a risk profile for the individual. The user then is able to speak to a mental health coach, typically a qualified nurse or social worker, who goes through what the results mean and helps the individual identify the most appropriate supports given their particular needs. These can be resources that are available through the individual's extended healthcare plan, through the public healthcare system, or a reliable online resource that is sent to them. Results from our pilot testing on this service have been very, very promising. We're finding that 80% of people using the service are in the moderate to high risk category, and that really is showing us that it's being accessed by people who most need it. And then over 60% of the people who do actually connect with with the coach end up seeing a psychologist after that consultation. And they'd never used their psychologist before. So again, it's really encouraging accessing services at an early point on. We're also seeing some very meaningful reductions in short-term disability durations and reductions in the percentage of users who are already on short-term disability that then progress to long-term disability. So this offering has real potential for preventing and mitigating the onset of more severe conditions. Finally, at Sun Life, I think one of the things that we've done is through our philanthropy program, we've made significant contributions to mental health. We've made that a real priority in our philanthropy initiatives, in recognition that really a corporation really needs to invest in enhancing global well-being and mental health. And so those are some of the things that we've done, and I think these have been really, really promising and impactful initiatives.
Sam, thanks very much. I think it sort of helps to bring alive some of the things that we have written in the report, and really talking about service innovations and the user perspective of what it's like to use some of the services. Let me go to Gordon. Gordon, I'd like to ask you, we talked about service, but we need to sort of get this started in the first place. You have worked with quite a lot of senior leaders and CEOs. How do the CEOs feel about mental health issues at workplace, and what kind of help do they need to get some of these services started in the first place?
Yeah, thanks, Ardita. It's a great question. I think this time 3-4 years ago, when I was speaking about mental health, no one wanted to listen to me. They saw it as soft and fluffy and whatever, and why are you doing this? But clearly now we have this shadow pandemic, and as you said at the beginning, COVID has raised the awareness, and people are now talking about it, which is wonderful. I think CEOs now feel the pressure that they have to do something from a good place. So this is a good thing. We have the Great Resignation, to the Great Evaluation, to the Great Engagement. And for me, the thing that I really want to get involved with and talk with CEOs about is the workplace. And as you mentioned earlier, the workers, 15 to 49-year-olds, women, etc. This is extremely, extremely important. So at the beginning, just when COVID started, actually, people were asking me lots of questions that I wasn't qualified, like Sam, to answer. So I started my master's in global mental health, which was wonderful. Clearly, I was the oldest student, and I learned so much. And when I was talking to my university, it's the University of Glasgow in Scotland, School of Medicine, and they asked me when I'm doing my dissertation, which I've just finished, and I've written a paper which we hope to get published. And the question, what they came to me and said, listen, Gordon, you have access to CEOs. And when we look at all our literature, we have all this stuff where we've asked employees, we'll get feedback in EAPs, et cetera, but there's very little research in people doing qualitative research to CEOs. So my paper was titled, how do CEOs really think and feel about mental health in the workplace, and where do they need help? So I spoke to CEOs from around the world, split 50% female, 50% male, to see if there were any material differences in the way that people approached it. As I say, they were from all continents in the world. And the bottom line is all of them really need help. And the thing that came across to me is they're asking for support, because when they go to look for mental health solutions, the market is really fragmented. They see meditation apps, they see yoga, they see some, cute little things, but they don't know what works and what doesn't. They go to their HR, and HR, depending on the company, some people have chief behavioral health officers, which obviously help coordinate, but what they were really looking for was almost like a single source of science-backed data, so they could have an integrated approach and tackle this holistically. They didn't know what to do. And interestingly, only of all the CEOs I interviewed, only one had tried their own company, EAP. And he said, I was really quite shocked because I thought we were great. And when he used the EAP, he really found it very impersonal, didn't help him at all. And really, it prompted him to take action. So if I look at what came out of that, there were really four broad themes. And number one was, I wanted to really talk about the cost of this, the financial burden, to talk to the left brain of a CEO or a CFO. And I was very encouraged that everyone understood that the financial burden and the lost productivity was there. No one disputed that, even though they didn't know how to measure it. No one disputed that. And you mentioned earlier, 6 trillion annual cost due to untreated mental health conditions. There are different variations on the number there, but the one you had was 6 trillion. So that's massive. And that's mainly not through absenteeism, which is very easy to measure. It's really presenteeism is, probably about 40 times more of a culprit from that than absenteeism. The second thing was mental health has to come from the top. It's not an HR issue, it's a leadership issue. And the CEOs need to walk the talk. They need to be authentic. And if they're not, it just won't have any credibility. And if you look at some of the recent reports, for example, the Ginger Group, the discrepancy between what CEOs think they're doing with mental health and how employees receive it is massive. You mentioned stigma. The third thing was really, and Sam mentioned this, doing this Sun Life, which is wonderful, is a better understanding of mind health by business leaders and the leadership teams, because they're actually pretty ignorant. We need to teach them, we need to talk to them. So they need to understand what good mental health looks like, how to identify people with potential mental health conditions in the workplace, and make the overused term, psychologically safe space that they can talk to. So what the last theme really was, this one that I mentioned at the beginning, is confusion, because people know physical health, but they don't know mental health because it's invisible. So they don't know if they're doing a good job. Are they improved? Where are they today against the best practices? They don't know. How can they measure if they're making progress? What does the science say that they need? So these were the main findings that the CEOs gave me, and these were from CEOs, not from some from the insurance industry, but from a variety of industries. So I think to answer your question, that is what is on their mind at this point in time.
Thank you, Gordon. And then you mentioned this real lack of knowledge or a confusion as to how do they know if what they're doing is good. I wondered if you can also share some examples about what you're doing in terms of helping them with evaluating some of this.
Yeah, well, I think, Ardita, the big question is, how do you measure the invisible? Can you measure the mental health of a company? Well, not really, no. But what you could do is you could measure how well they're doing against the best practices, for example, and publish that even. So we have been working, AXA, along with some other companies, have funded this initiative with Columbia University, who are doing all the science behind this, with a company called Ethisphere, who specialize in indexes, and One Mind is a large NGO based out of California in the US. So everyone has got together to see if we could create an index that measures mental health. So we've been working on this for a while. Dr. Kathy Pike at Columbia, that was our challenge. Can we measure the invisible? And we actually think that we can, and we've launched it. We're in the soft launch at the moment, the pilot phase, and it's due to be launched on May the 1st. So the index sets the standard of what good mental health looks like across 10 specific areas of improving your mental health culture. And what this will do, this is not for employees, this is for employers, so it's quite different. That will measure how good is XYZ company against those 10. So maybe you're 9 out of 10 for the first one, 2 out of 10 for the second one, etc. So it measures you. This is your benchmark. This is where at least you can start. You know how good you are. And then secondly, in addition to this, we have a lot of data, mainly from Columbia University, and this will only get better the more we do it with a lot of AI as well. So you will have, what are the 3 best practices that can help you in this, one of the 10 aspects of mental health leadership for a corporation? So you will get, these are the best practices, and it's science-backed. So what a CEO is getting is he or she is getting data on how they feel they're performing against the best in practice, evidence-based practices. They will get advice on maybe there's 3 they're not doing particularly well, which is the 3 areas maybe to focus initially on. And after the index assessment, the mental health at work index, the professionals will come and they will talk with you on what to do. There is an opportunity to have in the future, more consulting and walk with you along the journey. Some people maybe want to do it themselves. They have that chief behavioral health officer, etc., in their company. There are different ways to tackle that. So assessing the maturity of this could give you a number. So for me, my personal dream would be under ESG, if this index could maybe become the measure under the S, the measurement for mental health. I don't think companies would really want to publish it initially, but maybe in the future, companies would want to publish it, because CEOs like league tables, but only, of course, if they're at the top of the league table. And that's wonderful, because then, we talk about promotion of mental health. And you can, like my son just graduated, he was looking for a job. So he's doing this research on different companies and how they treat their employees, etc., and opportunities. This would be a further tool to measure and make mental health, not in peripheral, but to really the center of a company's culture. So that's what we've been doing, and this is kind of collective impact because we've worked with other companies. It's embryonic, but we're in the pilot phase at the moment. It's going better than expected. There's a lot of interest. People with many multinational companies talk to me about it, and we will launch this on the 1st of May. We need to make sure we're prepared. We can't do everything at once, but we're ready, for significant scale to do this. So we're very hopeful that this will be easy for people to see the first time how a company is performing against the best in practice to create a positive mental health culture.
That's really interesting, Gordon. Thanks for sharing it. And we look forward to hearing more from 1st of May onwards. And a mental health and workplace league table sounds interesting. Yes, I'm sure it wouldn't be without controversy, but nonetheless, a very, very good way of putting this on the mainstream. With that, let me go to Chris. Chris, you have heard from the previous 2 speakers from the industry about the actions that are being taken by insurers. But let's get a bit of a broad perspective here, broaden our horizons a bit. You are an economist examining how mental health affects labor market. Can you add some color to this by sharing what you see happening in OECD countries about policy response?
Well, thank you very much, Adrita. Good afternoon or morning, evening to everyone listening here. Congratulations also, Adrita, to this very timely report, which I think is very promising. Well, as I said, I have myself no link to the insurance sector at all, but I'm instead working for an international organization that is providing advice to governments on structural reform. And in this regard, I wanted to start by repeating one thing that you said and emphasize that yet again, that mental health is not just a health issue. And it's really a social issue, an employment issue, an education issue, a human rights issue. And I think that is so important because it's showing what the big challenge is for governments, and it's also the challenge for us as researchers advising governments. It clearly cannot be a discussion about the healthcare system and health policy only, but it really needs to be a discussion about actions and reform in all kinds of different policy spheres. And that is really a big challenge for governments. I also wanted to repeat that mental health is a long neglected issue. And that despite the reality that those people who experience mental health problems really have a much harder time in succeeding in school, remaining in employment, staying in good physical health. And just maybe to give you a few headline figures from our work, we found that adults with mental health conditions are about 20% less likely to be employed. We found that students with mental health conditions were about 35% more likely to have repeated a grade at school. We do find that about 1 in 2 of the long-term unemployed report having mental health issues as a barrier to returning to the labor market. And we also find that 2 in 3 people seeking mental health care report difficulties in getting it. We have actually started to work on this link between mental health and the labor market long before the COVID crisis, more than 12 years ago. And that was actually when we have discovered that this is the one health issue where we really know the least about, and the one that is creating the largest problems. The largest problems for labor markets, for our social systems, and also, in fact, creating the largest costs to the economy. And having worked a few years, and you have mentioned this briefly in your introduction as well, that Peter, we achieved something we were very proud of, that actually OECD governments, and it was actually the ministers of health, the ministers of employment, and the ministers of education have committed to developing and implementing better policies around a recommendation that we have brought out, which was called a recommendation for integrated mental health skills and work policy. And basically, we set out a couple of principles that policy should follow to create better outcomes by following a coherent set of actions across different policy spheres, but always following a certain logic. And the logic was essentially threefold. So the 3 elements of our recommendations were the following. The first was that it is critical to involve frontline stakeholders that normally would not be seen as mental health actors. And that is what we called the who of a good policy approach. The second element was that the focus would really have to be on early identification and early intervention, and that across all policy areas, which is what we called the when of a good policy approach. And the third was the aim to provide integrated services, integrated across health, education, and employment in particular, so that nature of service would look different from what governments and services, which are all working in silos, usually provide. That agreement was already 6-7 years ago. So 5 years later, a little more than a year ago, we have been looking into the policy progress that countries have achieved. And what we found is that countries were in very different stages in their development towards more integrated policy. And we found that countries very often go through 4 stages in developing this policy, which really tells you this is a very, very long-term shot to change things. First stage usually is the development of some awareness and corresponding rhetoric for necessary reform around a shift towards integrated policies. The second stage then typically is to build the foundations for such more integrated policies. The third stage is then often one of shifting from a few innovative trials to a more scaled up integrated approach. And the scalability issue we have heard is a big one for insurers as well. And only the fourth and last stage would be to actually provide properly integrated health skills and work plans in practice. And as I said, it's quite common for policy to go through all these 4 stages. Each stage can take years. And very few countries have ever reached the final stage in any of the policy fields we have been looking at. And we have been looking at the 4 policy areas in particular, which was education policy and youth policy, employment and workplace policy, social welfare policy, and also health policy, because mental health is also highly stigmatized within the health sector. And when we compared policies in these different fields across all the countries and following all the aims we had and these different stages, What we found overall is that there has been quite a bit of progress in policies to improve the mental health of young people in many OECD countries, with increasing attention to more integrated services delivered for them. This change is, for instance, reflected in a widespread effort in many countries to increase the understanding of mental health among teachers and educators, and also in funding dedicated to addressing mental health issues and to strengthen mental health support available to young people, and often within the school system. On the other side of the spectrum, we found that welfare systems have shown by far the least progress in OECD countries in terms of moving towards a more integrated approach. So the potential role of social protection, and particularly also employment services, in fostering an integrated approach really remains unfulfilled. Like, for instance, programs for the many people with mild to moderate mental health conditions who are in the unemployment system are completely absent, and that's really a missed opportunity. For mental health care, we find recently quite some expansion in some countries following many, many years of chronic underinvestment. But despite more funding being made available, this is not enough, so to speak. And in particular, it is still very much confined to health services themselves. So initiatives also within the health sector to involve work and employment considerations in the design of health treatment and health interventions also continue to remain very limited. And lastly, workplace policies, which is the ones which Sam and Gordon have spoken about as well. In this field, we see advances in many countries for a mix of regulations relating to psychosocial risk assessments and risk prevention. But we also find that these policies are pretty much disconnected from other policies, disconnected from the healthcare sector, disconnected from the social protection system. And I'm talking here about policy, right? Not about insurance. And for instance, again, one example, we do not find across countries really policies to support the mental health and the return to work of those who are on sick leave, which would be the moment to act and would be very promising. And lastly, we also find a very uneven development in the three aspects of what we call a good policy: the who, the what, and the when of the good approach that I had mentioned before. So we do see substantial progress in the who, with many countries making progress in equipping important stakeholders, including teachers, managers, caseworkers, even general practitioners, with a much better understanding of mental health and with knowledge on the critical links also between mental health and other spheres of life. But the other two sides of a good policy, we see much less progress, really. There are massive structural barriers still in implementing a whole-of-government approach. And the shortage of financing continues as well in all policy areas. And that really hinders the development of properly integrated interventions and services. And also the shift towards prevention, promotion, and early action is often more a rhetoric one, but not really happening in reality to the extent it could. And where early intervention happens, it still remains very much in silos and doesn't achieve crossing the different spheres of policy. So I think in overall terms, you could say governments really struggle. They struggle with breaking disconnected silos. And even though they increasingly understand that the gains that you would have might be accrued in another sector or maybe another ministry, it is very difficult for them to shift to such policies and to invest in an area, although it would actually bring gains elsewhere. In that sense, that whole of government approach to funding of interventions and to measuring success is in fact still largely absent.
Thank you, Chris. There are quite a number of questions that's been piled up in our Q&A section, which is a very good sign. I want to get to them as soon as I can. But before I move, I want to pick up on something that, Chris, you have mentioned, and maybe I'll start with you and ask Sam and Gordon about your views as well. You talk about the welfare system really not being able to grasp mental health in the way you would like it to see. In the same way, you also talked about workplace policies really not being very tied up together. Are there specific features in that workplace, in that economic space, in that labor market that, for instance, that we are failing to keep people healthy in the workplace in the first place? For instance, I know from our other conversation, we have said, well, insurers are doing it, but only doing with a certain segment of the workplace. There are all sorts of other workplaces that's been left out. Perhaps you can give me a minute of remark on that, and perhaps I can move on and ask similar questions and get Sam and Gordon your reactions to that as well. Chris.
So the question goes to me first.
Yes.
Yes. So I think what I wanted to say here is, and of course, I'm always kind of comparing policy and the role of insurers, right? What policymakers really have a disadvantage is that they usually get to act very late because they get the information they would need to act early too late. So in a way, governments really depend on the private sector for early intervention and early action. And governments kind of pick it up wherever early intervention has failed or has not happened, right? So in some way, these two sectors, the public and private sector, go hand in hand in the sense that the better the private sector doing is in an early phase, the easier it will be for the government at the end to pick things up. And of course, then in terms of the choice, where is something happening in the private sector? I think it typically is in large companies, right? Of course, both Gordon and Sam are representing really large employers, because insurers are obviously also among the largest employers. And where it is getting really difficult is small and medium-sized enterprises, which are the majority of enterprises all over the world, actually. And that's I think an important field where governments and insurers need to work together to ensure that those products and those services that large employers can either provide themselves or get through contracts with insurers, that we also find a way to provide the same support to small enterprises. That could be done in different ways, like the public sector covering some of those costs that otherwise would be too large for a small employer. But there's many other ways, I'm sure. And I'm sure insurers, and I hope insurers have good ideas on how they could leverage that so that they could reach small employers, because it's not always just a matter of costs, right? There's many other reasons why small employers would feel like they're not paying attention to that. Relates back to all the discussion, awareness, stigma, and so on.
Thanks, Chris. And if I'm very conscious of time, so I request Gordon and Sam to keep your remarks a bit short on this one, but I would love to hear, maybe start with Gordon, what are we thinking about in the insurance world when it comes to smaller employers, where the big gap is that Chris has just talked about?
Yeah, well, first of all, in terms of government private sector, the percentage of the health budget spent on mental health is, in LMICs, it's probably, if you're lucky, 4%, and it doesn't represent 4% of the burden as you demonstrated earlier. In terms of insurance, yeah, we need to start treating mental and physical health in a similar way. You may limit a visit to the psychologist to 5 times, but you never do that for chemotherapy. So we start to need to look at that holistically. And lastly, we need to go further upstream, as Desmond Tutu always says, rather than just deal with the downstream. And what we did with SMEs is, even during COVID, we had, again, working with Columbia, we had details for SMEs and what to do on, like a FAQ, but a playbook, I would say, and how to deal with the stress during COVID, which we made free to everyone. But yeah, those are, I keep my remarks short, but these are what I would say.
Thank you, Gordon. Sam, any remarks on reaching certain segments of the population or employers?
Certainly. One of the things that we have in Canada is something called the Chamber of Commerce. It's both a national organization that then has regional chapters and even local chapters. And it's really intended as an association, if you will, for small employers. And what they're able to do through the Chamber of Commerce, many different things, certainly some advocacy, speaking with government about the needs of small business and so on and so forth. But they also, through aggregating the membership, are able to provide the kind of insurance that would be available to large corporations at a reasonable cost or a much more affordable cost than if a single small employer was to try to provide that for their own employees. So it's a model I think that works well for small employers. Now again, we've talked about people who aren't in the workforce, and that really does need attention, certainly through government policy.
Thank you very much, Sam. We have a huge pile of questions from our audience, and it's fantastic to see the level of engagement. I'm not sure we can get to all of them, but I think some really interesting ones. Let me start with one, which is a big comment, but when that comes up, a very important point. Much of the philosophy of underwriting depends on the underwriter's own philosophy. So how, when we are talking about new ways of risk assessing, moving from binary models to multivariate ones, obviously the subjectivity of diagnosis in mental health still remains. Have you seen innovations as to how insurers are thinking about consistency in that decision-making when they are doing risk assessment, when they're underwriting a mental health risk? Any interesting observations there? Gordon and Sam, perhaps this is for you too.
Gordon, did you want to go first, or?
No, on you go, Sam. Yeah.
I think it's certainly a concern and a significant challenge. The sort of narrow view or perspective rather, that's been taken in underwriting does reflect a bias towards physical health. And it really underscores, I think, the limited knowledge and understanding of mental health. And so we still have a long way to go, I think, with respect to really revising and updating approaches to underwriting that really take into account the needs of individuals and don't then become barriers and sources of bias around the issues of mental health. I think one of the things that I hope has come through clearly in all of the comments made by Gordon and Christopher is that we can't continue to silo health and mental health. And I hope that was clear in the definition that I gave earlier on, that these are highly integrated aspects of our overall well-being. One does not sort of exist in separate from the other. We can take any single physical health condition and take a look at the impact that it has on a person's overall well-being and mental functioning. Conversely, if a person has a mental disorder or a mental illness or compromised mental health, if it's not at the level of disorder, we see fairly significant impacts on their physical functioning, whether it's sleep or their attentiveness to adequate nutrition and so on and so forth. So underwriting has to reflect that. Underwriting has to recognize that integration and get away from the issues of seeing things in a binary manner.
Gordon, did you have anything to add to this? Yeah.
As Sam said, there's no silver bullet here. It's difficult. It's not easy. It's still evolving. It's embryonic. It's again looking at holistic health. And when we look at the comorbidity between physical and mental health, both ways, it's quite astounding. So I don't have any magical answers. It's just it's a lot of hard work. But the key is we need to take this seriously and we need to do it.
Thank you. Related question comes from Anju Joy. In your experience of working in mental health insurance, how reliable is DSM? So Sam, perhaps this one is for you.
Yeah, I think that's a really important question. And this may not be a particularly popular view with some of my psychology and psychiatry colleagues. The DSM has certainly helped advance research in mental health by providing a system that allows us to have more reliability with respect to understanding a particular disorder. So from that point of view, it has been helpful. It's given us a common language, as has the ICD-9 or 10 or 11. The difficulty or the limitation is that it's very symptom-based, and there is a great deal of overlap in symptoms from one disorder to another. And so it results in, sort of an erosion of reliability when we're making diagnoses, which is in a way really counters the objective in the first place, and that is to have a consistent way of understanding a particular disorder. I think the other thing that has happened as a function of the DSM and the ICD approach to diagnosis is when we're focused on symptoms, we tend to take our eye off of understanding causal factors. And so when we take a look at evidence-based treatment, the way the field has gone is evidence-based treatment for a particular disorder. Yet we know that there's a fair bit of overlap between disorders. And what we really need and have underscored, I think, in some of the research literature is the importance of getting at root causes and treating root causes rather than just simply responding to symptom relief or symptom reduction. So the DSM is helpful and has certainly contributed, I think, to the advancement of science in the area of mental health, yet it still has its limitations.
Thank you, Sam. I am going to try and be efficient. There are 3 questions, and I think they all have a theme going about it. So the question perhaps could be to Chris, given you come from the policy side, are you seeing interesting innovations that talk about the sectors working together? So are there really good innovations that's happened with public and private in the mental health sphere that is that's noteworthy, that's achieved scale, and that's got some of the answers to some of the questions that we've been asking today?
Oh, that's a very good question. I don't think we see a lot of actual real strong cooperation between the public and the private sector in this regard. I think I'd rather see good discussions around what policy environment should governments put in place so that the private sector can actually act in the best possible way. And I wanted to hint one issue here that is maybe a bit contentious, which is financial incentives. Right? So for the government, this thinking of employers, it's very important to think of so what incentives could put in place so that we make sure that employers pay attention to these issues. Right? And for instance, around the whole sickness insurance issue, and that it could be, doesn't matter whether it is public or private insurance, both applies for both. The question is really important: in what extent an employer actually has incentive to take quick action, or rather has an incentive to wait and see and is eventually, depending on dismissal regulations and protection, dismiss someone as soon as they possibly can, rather than actually dealing with the issues they are facing. And in that sense, I think that's where public-private partnerships would be very important, because if we cannot achieve early action, and we can only achieve early action with the strong action of the private sector, we have massive costs at the end, and we have failure at the end, because we will lose people very quickly. There's one really shocking statistic. If you look at people who have been out of work just 5-6 months because of health issues, in most cases, they never return to the labor market anymore. So it's really shocking in the sense that the window where we can act, it's really just a couple of months. If we miss that, we will not achieve much anymore. And that's where governments struggle the most, because they have, usually we're talking about people who have been out of work for much longer than this, and then trying to create all kinds of programs and interventions to help those people, except that we know from the evidence that this will not help us very much anymore. We have missed that point. We have missed that chance where we could have made a difference. And that's why I think actually a strong collaboration between public and private would be hugely desirable, not in terms of the public sector blaming the private sector for not having acted and then carrying the cost, or the other way, the private sector pushing things to the public sector, but that really in a way coming in very early to support the private sector. And maybe one example I could think of is in Switzerland. I think the disability insurance, the public disability insurance, but Switzerland is one of those European countries where private insurance also plays an important role, much more so than in most other European countries. But the public insurance discovered that what they have had massively rising disability costs. And they realized, well, the reason for that is failure at the very beginning where we are not involved. So what they offered to employers directly is get in touch with us. As soon as you see a case where you think that could be an issue which could eventually lead to long-term sickness or disability, get in touch with us. So get in touch with the last insurer, the public disability insurance, at the very first stage. And we tried to, basically they tried to develop new interventions that employers can use at this very first moment, free of charge. The idea was really for the insurance, if they can get to the employer at this stage, they accrue massive savings later on.
Thank you very much, Chris, for that. I'm very conscious of time. We don't have a lot of time left, so I'm sorry that we can't get to all of the questions today. But we will try and respond to you offline to some of these. But I want to use one of the questions, which I thought it would be a good way to finish the webinar today, is what would success look like in 5 years' time? So Gordon, starting with you, what would success look like?
Well, number one, that the index becomes the norm. That would be success. But I think quite often we have these discussions, we talk about the first world, and we're talking, you know, as Chris was saying, quite rightly, but you mentioned shackling. You know, in Indonesia, there's Pasong where people get tied up. We need to do some basic things in the emerging countries that we're not doing, just so that mental health is recognized as an illness. So for me, I think, you know, we're two speed here. We can't just talk about the high income countries. We really need to look at the low and middle income countries, and success there is quite different. So I think in the higher income countries, something like an index, I think would really help. So employers take that seriously. And then more basic things. And of course, in different countries like a Singapore, you know, really getting the government, and they're making progress now so that people talk about it. This is everyone's business. It's not just a private matter. And it's shared value. If we get mental health right in the workplace, it's good for the employee, but it's awesome for the employer as well.
I'll just unmute myself. Thank you, Gordon. Let's go to Sam. Sam, what would success look like in 5 years' time?
Yeah, I agree very much with Gordon. I think public education geared towards helping people understand the nature of mental health and the integration, the synergy between mental health and public health. So I think public messaging is something that is a really critical responsibility of government. There are relatively low-cost interventions or initiatives, again, that can be undertaken by government. When we take a look at most mental disorders, they begin early on in life, certainly by age 14. There's a program that comes out of Australia called Positive Parenting Program, which has very strong research behind it. Again, that program goes a long way towards helping parents understand some of the ways of dealing with children around age appropriate sort of interventions or approaches to teaching, discipline, and so on and so forth. Those kinds of initiatives, I think, are incredibly important. I think the other thing that I would see as a sign of success is, at this point, whether we're talking about the developed world or the developing world, is, you know, people go to a health clinic or go to their family physician, typically a general practitioner. That's the entry point into the health system. What we've been arguing for a long time is the importance of an integrated multidisciplinary primary care. rather than care that's delivered by a single practitioner. So this would be a physician working alongside with a mental health professional, psychologist, social worker, perhaps a dietitian, really important critical aspect, perhaps a physiotherapist or an occupational therapist that again address the essential components of overall health and mental health.
Thank you very much. And lastly, Chris, and if I may ask to keep your comments very brief because we are just out of time. So thank you.
Well, two issues, both one sentence each. The first follows up on what Sam just said, that we always use the phrase that wherever someone enters the system, he or she should get the same type of integrated service. It should not matter whether you're first seeing a GP or it first pops up when you're talking to your counselor in the unemployment office. And the second issue for governments, the key is if we manage to break the silos, especially also on the funding side, so that we understand investing in one sphere is actually bringing gains anywhere and everywhere, and that we do not measure success only within silos and therefore restrict funding to silos.
Thank you very much, Chris, and also for keeping it very brief. With that, I'm sorry we have really run out of time. I would like to take the last minute to just thank our great speakers. It's been a very productive conversation, and I hope we can keep having these conversations. Thanks to all our audience who have joined us from everywhere. I can see that some of you, it's been either a very early morning or a very late in the evening. And to my wonderful GA events team who have made this happen quite seamlessly. Let me again remind our audience to kindly fill out the survey that's going to come to you in a minute as soon as we sign off. With that, thank you again for joining us today. Goodbye and have a good day.